So we move on to the next speaker, Dr. Vijay Gangavarapu. He will be speaking on pansinusitis, presenting as unilateral orbital cellulitis, a case report.
Good afternoon all. Good afternoon dignitaries on the dais. So the topic of presentation is already read about. So introduction, sinusitis and orbital cellulitis are most commonly encountered clinical conditions in the practice with overlapping symptoms, making an accurate diagnosis crucial for appropriate management. Up to 86 to 98% of orbital cellulitis cases have a coexisting rhinosinusitis. It is mostly seen in young children of 5 to 15 years age. The most common organisms in bacteria, that is Staph aureus and Streptococci. In fungal, mostly Mucor and Aspergillus, and in helminth, it can be hydatid cyst. The presence of ophthalmoplegia, pain with eye movements, and presence or absence of proptosis is the most distinguishing feature of orbital cellulitis. So here, we present a unique clinical scenario of a patient, young boy, with pansinusitis, whose initial presentation mimicked unilateral orbital cellulitis. So a 14-year-old male was referred to an ophthalmology OPD from ENT department for query left eye orbital cellulitis with chief complaints of left eye diplopia, protrusion of eyeball with lid swelling, redness, pain on movements of eye, and pain in the maxillary region, which was insidious in onset, gradually progressive, dull aching, and present throughout the day with fever. All were seen since 1 week. On examination, a tenderness was noted on the left orbit with restricted eye movements, eccentric proptosis, and ophthalmoplegia with diplopia, chemosis, swelling of upper and lower eyelids. On ocular examination, right eye was normal. The left eye, the visual acuity was reduced 6/9, and color vision was reduced 34/36 lights. The globe was intact with 10 degrees of exotropia and eccentric proptosis. On head tilt, it was 25 mm. Orbital margins were intact. Eyelids, they had upper and lower lid swelling. There was mild lagophthalmosis. Conjunctiva had chemosis. The cornea was normal. There was corneal sensations were intact. AC was normal. The pupil had grade 1 RAPD changes. Lens was clear. Extraocular muscles, there is restricted mobility of grade -2 in all cases. Digital IOP was hard. On fundal examination, the right eye was normal, and the left eye, we had mild hyperemia of the disc without any peripapillary hemorrhages. The left eye had FR dull, foveal reflex was dull. Investigations, blood investigations, CBC, we had hemoglobin of 10 gram per deciliter, and WBC, mild leukocytosis was seen. Other blood parameters, serology was negative. He was ruled out of type 1 diabetes and type 2 diabetes. Thyroid profile was normal. LFT, RFT was normal. ECG was normal. Urine examinations were normal. CT orbit, they showed suggestive of left orbital subperiosteal abscess. CT PNS, there was mild pansinusitis. MRA orbit showed signs of optic neuritis and pansinusitis. On culture and sensitivity, there was methicillin-resistant Staph aureus was identified, which was sensitive to vancomycin, linezolid, meropenem, and minocycline. Here we see the left eye pansinusitis, which was also seen as subperiosteal abscess. There was a laterally displaced optic nerve, and the orbital subperiosteal abscess was compressing on the extraocular muscles, causing optic neuritis also. The treatment was, he was started on intravenous vancomycin, ceftriaxone, and metronidazole. Surgery was done because of progressive worsening of symptoms. Emergency septoplasty with FES with left orbital decompression was done. The visual acuity progressively improved, and in post-op day 14 of MRI was done, and there was a marked reduction in subperiosteal abscess. There is complete resolution of pansinusitis. Discussion, the clinical presentation helps in promptly recognizing cerebral orbital cellulitis. Diagnosis and investigations like CT and MRI are most important. In management studies, early intervention by antibiotic therapy is most crucial. In periodic considerations, a high index of suspicion helps in better early resolving of the patient complaints. And prognosis and follow-up is also very important in this case. Last, the conclusion is that early recognition, prompt diagnosis, and timely intervention of orbital cellulitis is most important in pediatric patients, and it always needs a multidisciplinary approach involving ophthalmologists, ENT specialists, ID specialists, and pediatricians. So this was the first day 1 picture. After post-surgery, he had mild subconjunctival hemorrhage, and after 2 months follow-up, the child was totally resolved of all the complaints. Thank you.
How did he land up in the ENT department?
Ma'am, he was a known case of chronic sinusitis.
Because if you see in the picture, there's some swelling of the lateral wall of the nose also.
Yes, ma'am. Actually, they suspected there might be mucormycosis. So they sent for us for the opinion of ophthalmology to rule out mucor. But instantly, we found out that it was actual, after investigations, it was not mucor as such. They were planning for a treatment of amphotericin.
Okay.
How common is mucor in
Children.
small?
Yes, ma'am. In our area, they were thinking the child is debilitated state. He was maybe because of his thin build, he might have been immunocompromised. And in our area, there is some higher chances of mucor relatively, but not in this young case.
How many cases have you seen like in small children, mucor?
Ma'am.
There was so much of mucor in the COVID, post-COVID
Yes, ma'am.
era.
But only one or two, ma'am, not many. That too, they were already having type 1 diabetes, pre-existing immunocompromising state they had. Those children, what I've seen, they were already immunocompromised, not this child.
And the septoplasty and orbital decompression were done in one sitting?
Yes, ma'am. By the ENT, endonasal approach was done, ma'am.
They did the orbital decompression.
Yes, ma'am. What they did is they did ensenectomy. First they did FES because it had a DNS, and then they went up. Ensenectomy was done, and then they lifted the laminar papracia just to create an opening for the drainage.
So all of the treatment was done by the ENT people.
Yes, ma'am. But initial treatment, we started with all the antibiotics, ma'am. So first they advised to rule out mucormycosis. They asked an opinion for the antibiotic treatment also. So what we started on ceftriaxone. Then we said that this was not mucor as such. And then after B scan and all, we ruled out that it might go towards orbital cellulitis.
What made them think it could be mucor? I mean, there was nothing to suggest that it is mucor.
Yes, ma'am. They were saying that the patient had chronic, they were thinking it was chronic
fungal sinusitis
Yes, ma'am.
of any kind. Like mucormycosis is something very specific subset which comes
And
out
since it was unilateral also, they were going more towards that. And the patient was very thin built.
very.
Thin built, ma'am. The child was a bit
Actually,
weak.
my contention would be it is a very, very expected common case.
Yes.
Yes, ma'am.
It's very much expected. Pansinusitis will present like this. It's nothing uncommon.
Okay.
In fact, children or whatever, patients come in with orbital cellulitis and the investigation is a CT or whatever, an MRI, and it leads you, most commonly you get sinusitis. Ethmoiditis is one very common cause, and you have to keep the ENT people. Usually most of the orbital cellulitis gets referred to ENT people for this.
Ma'am, the other case was the patient also had RAPD changes also, and also
Yes,
ophthalmoplegia.
yes.
So
I
they wanted to know
recently, we had
post-operative prognosis of the patient, how it
Yes,
would
you
be.
can get PL negative also, you can have it. But then this could have been started by the ENT people also, what you guys did, right?
Yes, ma'am, but they were not sure. They didn't want to put the young boy for the loss of vision, complications of that.
ठीक है.
Thank you, ma'am.